This is Blood and Cancer, the official podcast of MDedge Hematology Oncology. I'm the voice of MDedge Podcasts, Nick Andrews. And welcome to Blood and Cancer. I am Nick Andrews, and I want to start this episode by saying that at MDedge we are aware of the current climate in the country, and as an organization that serves physicians and other healthcare providers, we are doing a special episode of our sister show, the Psychcast, featuring Dr. Lorenzo Norris, who is an African-American psychiatrist and the Assistant Dean of Student Affairs at George Washington Medical. That's episode 120. As you're listening to this, if you listen on Thursdays, that episode is not out yet, but if you're listening to this after the fact, that will be episode 120 of the Psychcast, and we'll get into practicing as an African-American or black physician in the United States, as well as a bunch of other things that people are experiencing right now. So we do not want any of you to think that we are not paying attention to the situation, and we think that this is the best way to respond. So we encourage you to search for the Psychcast, episode 120. And welcome. That's Dr. David Henry. I'm joined this week, as I always am, by Dr. Henry. And we are literally not even halfway through 2020, and it has already shaped up to be quite the year.
Boy, has it ever, for all of us personally, for all of us professionally, and then, of course, for us as healthcare providers and our patients. So what next? Tornadoes went through Philadelphia today, and so my son, as a young GI doctor in Philadelphia, called me and said, what's next? And of course, the big upset in the country about what's been happening in protests, as you just mentioned. So it's a lot for people to handle. And to keep us on focus, what we're talking about today, we're going to be talking about an interview with Dr. Jack West about lung cancer. But before that, we're recording this just after ASCO, which occurred this past weekend. And I was telling my friends, I'll be in Chicago. They said, "Are you crazy? You can't travel." I said, "I'm not traveling. I'm sitting at home for 4 or 5 hours Saturday and Sunday while your personal life spins around you downstairs." And went to ASCO, which went amazingly well.
Yeah, you give 5 stars.
I can't take my hat off enough to the ASCO staff, Dr. Skip Burris, our outgoing president, too. If you all haven't seen it, you should at least listen to his speech about what it was like. He's a wonderful man, physician, caregiver, and his career in caring for patients, oncology, clinical trials. He goes through all this, was really excellent. And then the meetings, a little bit of unstable. I would tell people I was unstable. They said, "We knew that." I said, no, my connection was unstable. And from time to time, it blipped a little bit because so many people were on, thousands. But then they ironed it out, and now it's all after the fact available. So you can all go to Best of the Day. The presentations were just great and are all available online. And to give one shout out that we're going to do this week, Dr. Alan Litz and I will record after the fact some hot stuff from ASCO that'll probably air in the next week or two.
Yeah, and it give people a chance to kind of digest the meeting and give your guys' thoughts on that. So that'll be great. So here's the question though. So as a journalist and kind of a storyteller and just trying to keep my finger on the pulse of what's going on in oncology, I like the watering holes after the day's sessions. I go to the bars, I go to the restaurants, I kind of do some schmoozing, and I get stuff that we might not necessarily report, but just to kind of check in with the specialty on what's going on. Other than that kind of thing and networking with people maybe you went to med school or did fellowship with, is this, for someone who's just practicing and doesn't maybe want to travel, is this a better way to do ASCO?
I think there's no question that will resonate with many people. I've been going to ASCO a long time. I went to ASCO when it first started. It was 2 hotels, and now it's major, massive conference centers. So I think over time it has become less relevant for the general practitioner. And I'm a general practitioner. I go because I'm involved with other things, but I can see that it's less useful for the general practitioner who waits for the hot stuff, all this wonderful new stuff presented to be digested, distilled, and how do I put this into place? And he or she could just watch that online and get the best of the day and the discussants to kind of put it all together. I still think there's a reason to go to Chicago, if that's where it's going to be for the next few times, to do all this networking. But I think the online will work for a lot of people going forward.
Yeah, I think that's one of the silver linings we'll take away from the pandemic is that a lot of things a lot of people have theorized you can do it online, and now that you have to, you think, yeah, it's not that big of a deal. But, you and I have been doing this Zoom thing for a while, so we're practiced. So let's talk about our guest. He's a recurring guest, and he knows quite a bit about cancers of the chest. Of course, social media lung cancer influencer Dr. Jack West returns to Blood and Cancer to talk about what's new in lung cancer.
So this was a great interview coming up momentarily. Jack and I talked about some specifics in clinical trials, so maybe 2 months ago in lung cancer. And then with this one, I posed the question to him. I said, well, we have checkpoint inhibitor single agent positive trials. We have checkpoint inhibitor and chemo single or doublet, so 2 or 3 drugs. And then finally, you can even add bevacizumab so that you have 4 drugs and, of course, quite a tab. When would you use which for whom? And he, of course, does a very nice job of decoding that and making it clear where you might want to jump in with everything or just one or some combination thereof. And of course, do your mutation testing. We touched on that as well.
So Dr. Jack West, of course, you can see back episodes with him by searching in your podcast search bar. They're also linked in the podcast show notes, written by our MDedge Hematology Oncology editor, Mary Ellen Schneider. And she is a fantastic person who works behind the mic. She's a producer and executive editor at MDedge, so she wrote the show notes this week, so you can see that there. Yeah, love to have Jack on. I think Dr. West we should probably check in with him, I say once a quarter, once every about 10 to 15 episodes wouldn't be a bad deal to just check in what's going on in the chest. Yeah.
I hope you'll enjoy it. Here comes Dr. Jack West with a wonderful update and kind of 30,000-foot look at the field and who to give what when in lung cancer.
Yeah, absolutely. And I'm glad you and I both, as we record this in Philly, we survived the tornado warning, first one of the year, many more to come. And we're going to survive 2020, Dr. Henry. It's going to happen.
I think so, too. Right. Everybody stay calm. We'll get through it.
Dr. Jack West coming up after this.
Thanks, Nick. I'm your host, Dr. David Henry. You're listening to our podcast, Blood and Cancer, and I'm delighted to be interviewing today a friend and colleague and a wonderful thought leader in lung cancer, Dr. Jack West, who is a medical oncologist and associate clinical professor at the City of Hope Cancer Center in Los Angeles. And Jack, thanks for joining us today on this podcast.
It's my pleasure. Thanks very much. It's great to have such a dynamic field where we need to have ongoing discussion to shift how we approach so many patients with cancer.
Well, I think in this electronic age, not only with cancer, but you're probably getting, like we are, these COVID updates. We're recording this right in the middle of May 2020, and we're getting updates almost daily. I'm part of PEN from the university and from the city and then the region. And, what do we know about it? Is it a coagulation problem? How does it handle cancer? So thank goodness for electronics. I don't know how we would keep up if it weren't for all this information flow, almost overwhelming.
I agree. I also think it's, now that we're social distancing and working from home a lot of the time, it's really helpful to be able to access stuff online, on demand, through social media, et cetera.
Indeed, and you're probably getting adept at telehealth, as am I, although I'm trying to dial down the videos because my hair hasn't had a haircut for 7 or 8 weeks, and I'm starting to frighten patients. So that we don't frighten our audience, I wanted to pose a couple questions to you. We did a wonderful interview about 2 months ago, if you want to listen to what Jack and I spoke about, and some data detail of first-line and second-line metastatic lung cancer about 2 months ago on our webpage, mdedge.com/hematology-oncology. So I thought the first question I would pose to you, Jack, today is, thinking of a new non-small cell, let's say adenocarcinoma metastatic patient, first line, in whom you've checked for driver mutations and there is none, I know we have data for, and I think approvals for, immunotherapy only, immunotherapy doublet chemotherapy, or the 4-drug combination of bevacizumab, pembrolizumab, and chemotherapy. So how are you choosing among those 3 possibilities in this first-line metastatic patient?
I would say that in most cases, I'm really just focusing on the question of whether they're best served by pembrolizumab monotherapy or a chemo backbone with concurrent pembrolizumab. And the main decision is first looking at whether they're a candidate for chemotherapy or systemic therapy in general, but then PD-L1 status. And I would say that we have strong data, particularly from the Keynote 024 trial, that shows that patients with high PD-L1 over 50% or greater, or about 28 to 30% of the broader population with advanced non-small cell have high PD-L1s. These are folks who can do extremely well with pembrolizumab monotherapy, much better than conventional chemotherapy. And so I would say for these folks, pembro monotherapy is a very strong consideration. We also have a competing first-line indication for chemotherapy concurrent with pembrolizumab in patients with high PD-L1, specifically the Keynote 189 trial with cis or carbo and pembrolizumab. Cis or carbo with pemetrexed and pembrolizumab, and that is anywhere in the spectrum from less than 1%, negative PD-L1 to high, and we have that for patients with non-squamous histology. For squamous histology, we have a very similar trial that showed superiority of chemo pembro over chemo alone, with a chemo backbone of carbo with either standard or nab-paclitaxel, standard solvent-based paclitaxel or nab-paclitaxel. And that also was anywhere in the spectrum for PD-L1 expression from 0 to 100%. So you could do either for patients with high PD-L1. I would say that it's a complete judgment call about whether to favor single agent or the combination. I really prioritize just trying to clarify in my mind whether this patient has room to progress clinically and radiographically without missing that opportunity for chemotherapy. So if they have a high tumor burden and seemingly rapid progression of disease, if they're symptomatic and losing weight just during their workup and you are seeing worsening disease between their initial CT and the ER and then the PET CT at the end of their workup, those are patients who I would not put all of my faith in pembrolizumab, but would think I may only have one shot on goal and favor chemo-immuno for those. And for a patient who has relatively minimal disease and not that symptomatic, and particularly for patients with the high end of high PD-L1, like 90 or 100%, there's data to show that those are the ones who have a really quite high chance of responding. And so I might favor single agent. For patients who are less than 50%, whether it's 1 to 49 or less than 1%, and frankly, whether it is squamous or non-squamous, chemoimmunotherapy with pembrolizumab is a very strong choice. And I would argue a superior choice to consideration of pembro, even though there is an FDA approval for pembro in the 1 to 49% population. It's not a strong option. It's really, I would say, very likely inferior to chemo with pembrolizumab. So I would not favor a pembro monotherapy approach for those with lower or negative PD-L1. There are other regimens, actually. One that I was the first author of one of the of a paper for Empower 130, which was carbo and Abraxane with atezolizumab in a non-squamous population. There's an FDA approval for it, but it's really hard to see how this is meaningfully better than the chemo pembro options we already had and that have more study for them. Similarly, Empower 150, which is the 4-drug regimen of carbo, paclitaxel, bev, and atezo, is acceptable. It's an FDA-approved regimen for non-squamous histology anywhere in the PD-L1 spectrum, but it's a little more cumbersome. I would say not as patient-friendly. I would prefer to give carbo and pemetrexed with pembrolizumab for my non-squamous patients over a 4-drug regimen of paclitaxel. So totally acceptable, but I don't see an incremental benefit over my kind of default standard of a chemo, carbo doublet. Yeah.
So in the COVID era, let me just put put in this question, we're being tasked and asked to try and keep patients away from us as much as possible. Have you had any luck doing maybe starting a patient and then switching to some of these at home, infusions at home of any of this?
I haven't done that yet, but I would say that it would certainly make us be more judicious about the chemotherapy, and particularly when we now have an FDA-approved pembrolizumab regimen of every 6 weeks.
Yeah.
I think that the concept of a limited course of chemotherapy followed by maintenance pembrolizumab every 6 weeks is attractive, or perhaps to lean more toward pembro monotherapy over chemo pembro with regard to risk of COVID, and both for exposures and for just giving immunosuppressive chemotherapy. We don't want to be gratuitous about that. So I think we need to be mindful of where we are treating a patient and how high the risks are just for coming in every 3 weeks, particularly and if we're immunosuppressing patients. So
yeah, so I'm hearing
I think it's a factor. Yeah.
It depends on circumstances, the performance status, amount of disease, and maybe get a response up front with more drugs and maybe divert to less drug outpatient. Might make sense. All right. So
so if I can just enter the thought that we're going to see the results at ASCO now coming up just a couple of weeks from now for Checkmate 9LA, which is Nivo and ipilimumab with just 2 cycles of chemotherapy initially, and then dropping the chemotherapy after those 2 cycles and continuing with the immunotherapy for longitudinally. And specifically, the Nivo is the only one that would really be ongoing after initial 4 treatments with ipilimumab. So I think that's going to introduce this concept of maybe pruning back from what we have been doing, which is sustained ongoing chemoimmunotherapy with maintenance pemetrexed and pembro. Maybe that's more than is necessary, and particularly if that's tethering a patient to a 3-week schedule and immunosuppressive treatment, if they don't need it, I think it will be really interesting to introduce this concept of very time-limited chemoimmunotherapy followed potentially by a more longitudinal but not very frequent immunotherapy alone.
Well, it's a really attractive concept. You know, we're seeing that in lymphoma, in breast cancer, to get a response, and then as you're getting the patient better in response, not just keep hitting with the same aggressive regimen and dial back. So let me then move on. So that's very clear and very helpful. So let's move on then. I'm reading that many as a third of patients might have a driver mutation. So, of course, we're checking for that and trying to wait if we can to get the result. Sometimes we can't wait. And on the heels of that, just this month of May, I saw an FDA approval of cabmatinib for a MET exon 14 driver mutation. So maybe if you could use this to explain, how do you pause in the new patient? What do you send? What are you looking for in the mutations? And maybe a comment about cabmatinib and MET exon 14 mutation.
So I would say that, in fact, just in the last couple of weeks, we've gotten approvals not just for cabmatinib for MET exon 14, but also for selpercatinib, which is a new agent that is for RET positive lung or thyroid cancer.
Really? So I hadn't seen that. Really, so we have two this month, yeah.
Mm-hmm. Yeah, and they're very similar. These are 2 agents that really fit the bill of the idealized targeted therapy for a specific target. It's a small population in the range of 2 to 4% of patients with advanced non-small cell, and these agents are extremely effective with first-line activity greater than 50% response rate and intracranial responses and really well-tolerated treatment. So these are extremely effective and follow the pattern that we've come to expect with our best EGFR inhibitors, ALK inhibitors, ROS1, et cetera. And so it gives this promise of a remarkably effective treatment both for intracranial and extracranial activity that has the potential for extremely longitudinal treatment with an excellent quality of life. So that's wonderful. The downside is that you need to find these targets to avail ourselves of them. And I would say a big challenge is that, of course, you can't just send off serial tests for 8 different things. At this point, I mentioned several already. We've had EGFR and ALK, and then ROS1, BRAF V600E, NRG1 and NTRK, and now we have MET and RET. So once you get beyond 3 or 4 of these targets, it really, to me, just makes incredibly more sense to roll it all into one package and send off for broad molecular testing, not a la carte testing.
And are we able to do that? Can we do that? Can we do that now?
Well, we can, or you can do that with tissue. And I think the biggest challenge with tissue is both the availability of enough tissue from sometimes small biopsies. So we always want to get as much good tumor tissue as possible in the initial diagnosis of a patient. And you can increasingly do that with liquid biopsies. And liquid biopsies from a plasma test can have good sensitivity, frankly, certainly for those patients with a higher tumor burden, not tumor mutational burden specifically, but actual burden of disease. Mm-hmm. As long as if it's not just a couple of small nodules, but people who have disease in their liver diffusely are particularly likely to have shed tumor DNA, circulating tumor DNA that can be detected on a plasma NGS platform pretty reliably, and also can have a turnaround time of more like 5 to 7 days instead of several weeks. And I think that right now, one of the biggest limitations we have is when NGS takes 3 or 4 or more weeks to get the results back, and you have a patient in front of you. I think I think it is increasingly important, bordering on critical, to send off for the whole panel and get not just the results of a top 3 or 4, but fully 10 potentially relevant markers for now, and maybe 2 or 3 more that are emerging in the next year or 2.
Now, are you sending tissue and liquid biopsy same time, preference one over the other? It sounds like a timing issue is better with liquid.
Yes, I think you individualize. Ideally, you'd love to send tissue right away. I think some of it is just what is going to be covered. You don't want to stick a patient with the bill, but I think the most reliable method is to send blood and try to get that answer quickly. And if you can find a result, if you find that someone has a driver mutation, perhaps not follow up on the tissue test and cancel that. I think there is a value to a belt and suspenders approach. I mean, if you get a negative result from blood, it doesn't mean that it's a true negative. It may just be a sensitivity issue that you could pick up on for tissue. But so I think tissue is a longer backup plan. But if you have someone with a pretty significant volume of disease and you haven't sent off any tissue yet, I think that you can hope for a quick answer from plasma and potentially act on that within 7 or 10 days.
It's always amazed me they can do this, a liquid biopsy, that they can find it and analyze it and give us a result. It's incredible. Well, I wanted to next move to increasingly patients are coming in. Everybody's aware of COVID era and they don't want to get sick. And gee, I've got lung cancer and I'm immunosuppressed. And they say, I've heard that this checkpoint inhibitor immunotherapy makes me sicker if I get COVID. Do we know anything about that yet? Is it too early in the epidemic to say something in our lung cancer patients on the checkpoint inhibitors?
I would say that there really isn't a clear enough signal to say that there is a smoking gun association of higher risk with immunotherapy and higher risk of complications with coronavirus or COVID-19 complications. I personally certainly respect the risk and would want to minimize that as much as we can. But I also think we need to prioritize the problem that people have over the theoretical risk that people could get. We know that having advanced cancer is a challenge, is a bad thing, and that we can sometimes have remarkably gratifying results with immunotherapy. And so I would say that if it is somebody who has a 90% PD-L1 tumor, PD-L1 expression, I wouldn't be gun-shy about initiating immunotherapy for them. It'd be different, I think, if patients had a known coronavirus infection and was minimally symptomatic from both their cancer and the coronavirus. But I think overall we need to really prioritize the problem that people actually have over the risk of a subsequent problem they may or may not develop. As I said, we are certainly mindful of the potential risk of an association of checkpoint inhibitors with higher complication risks, but it is not such a clear association that has been obvious to see up to now.
And on the heels of that, another issue that comes up with the COVID and cancer and patients with COVID and cancer is clotting. So these reports keep coming up more and more that the VTE, venous thromboembolism risk, is much higher. We saw a report in April in Thrombosis Journal that it was in an ICU where it was typically 5%. They're seeing 30%. How about in your lung cancer practice and at your center, more clotting than you would have expected, DVTs, PEs?
Well, I would have to give the caveat that where I am, we are fortunate that we are not having a big run of coronavirus or positive results. We have a small volume, much smaller than in some other centers. So, as I said, I think it needs to be viewed regionally.
Certainly.
And I've read some of the same things as you. I'm very struck by the association of coronavirus or COVID-19 with thromboembolic complications. But I think we're still running protocols to figure out how best to manage this. I would be reluctant to jump the gun and initiate treatment changes based more on theory than actual demonstrated results at this point, just because I think this is, of course, thromboembolic complications are always a balance of bleeding and clotting, and I think the stakes are high. I would really prefer to have this work be in the context of a clinical trial or in the wake of actual data generated from them.
Sure. Well, thanks for that answer. And then lastly, the Nextgen sequencing, I have found some of it hard to interpret, and you may have in front of you something I sent to you just to look at a patient I got, because they get really down into the genetics at the nuclear level, at the DNA level, and see if you think any of this makes sense for this particular patient. There were 4 points in this particular Nextgen sequencing of this lung cancer patient, metastatic non-small cell. So the first said Iridia, a frame shift from exon 7. Now, they give you a number of hits. This was 7,800 out of 13,000, so that sounds like it's significant. Then the second was there's a number gain of MET, and there were a lot of changes there. A nonsense variant PI3 kinase, which of course we're looking for in breast cancer. This was 15% in this particular allele. And then a nonsense variant in the one we hate to hear, TP53. So any of that makes sense in your trying to decode a Nextgen sequencing report?
Well, I think you bring up one really critical issue, and that is that the challenges we have in actually executing on the promise of precision medicine, precision oncology, is fraught with a ton of moving parts. And I think, as I already alluded, you need to have enough tissue, you need to send off the NGS and get it back in a time frame before you've approached the median survival of patients who are waiting for these results to start treatment. So, and people need to be able to see the results. They can't just go to a pathology department and then get uploaded into Epic, a media tab, never to be seen by human eye. And then if people do actually see that, they need to be able to understand them. And I am concerned that often they are extremely Byzantine. They're remarkably complex. so that even an earnest oncologist who gets these results can't clearly see how to use them. And I think that there are cases, what we've seen is that when you do get results of an activating EGFR mutation or an ALK rearrangement, too often they're not acted on for unclear reasons. And one of my fears is that that may be because if it's listed in the middle of a list of 20 different mutations and most of them are garbage, you're just making it hard to find the signal in the noise there. And too many of these companies are, chest beating about how much crap they'll find, as if volume is an indicator of quality or justifying the cost of a test. You develop this arms race of all the things that they'll find. But I don't think that's valuable at all when you're just looking for 10 or 12 things that have data to support them, and everything beyond that is just running interference with what you're actually trying to find. So to specifically get to your point, I think MET number gain, copy gain, MET amplification is arguably important. I think you really need to see the nuance of the numbers, and the data are not as compelling as with an exon 14 mutation. So a doc and a patient need to understand that when they're prioritizing if or when to pursue some MET-based treatment, that these are not the same results that you could expect for giving a MET inhibitor to someone with a MET exon 14 mutation. And certainly, many of the others that you mentioned are potentially the subject of a clinical trial if there's one readily available, but they're not in the same category as finding an activating EGFR mutation or ALK rearrangement. And I think it's a problem if patients and or oncologists think that if they just stare hard enough at the data cover page or two, that every cancer is going to have some miracle targeted therapy if you just force the issue. I think the reality is that it's a growing sizable minority, but the majority of people are not going to have an astonishingly effective targeted therapy with a kind of one-hit approach.
Well, to help understand these results, is there a website or a Nextgen sequencing 101? How do you keep current on what means something and what doesn't? Because there is such a wealth of data and variation. It's hard for the average clinician, I think, myself included, to decode this every time.
Well, I absolutely agree. There are some services like OncoKB, which is running out of Memorial Sloan Kettering, and other databases. You could really just introduce or just enter that into the details of the mutation onto Google and maybe find some mention somewhere. But I would say this is a really, really long tail. This is not something that you're going to be able to keep in your head. And so this is a time when we really need the wisdom of crowds and to look at some of these genomic databases where people are just entering their one-off, two-off results to see if you can glean anything from the responsiveness of this or that specific mutation to an attempted treatment with a RET inhibitor or a MET inhibitor, et cetera. This or that rare EGFR mutation may respond, but it's not one of the common ones. And so there's going to be essentially an endless list of rare to super rare mutations. And the best way that we're going to find that is by aggregating our results in some of these genomic databases that are out there and public as a service. And potentially, I think this is one of the other areas where artificial intelligence could be a real killer app in oncology.
Right.
Yeah,
sure could. Well, I think that prompts me to say we have show notes after this interview of what just took place, show notes, bullet points, and we'll try and include there some websites like the Sloan Kettering one to help decode. I know I'm going to go there when we get off to search this patient. Well, Jack, I want to thank you so very much. We've been interviewing Dr. Jack West, who's a wonderful thought leader and colleague in Los Angeles at the City of Hope Cancer Center, where he's a medical oncologist, an associate clinical professor of medicine. And Jack, thanks so much for joining us today.
Always a pleasure.
And that concludes episode 73 of Blood and Cancer. Blood and Cancer is produced by the editor-in-chief of MDedge Hematology Oncology and the host of this show, Dr. David Henry. All MDedge podcasts are produced by our editor-in-chief and the editor-in-chief of Medscape, Dr. Ivan Aransky, as well as MDedge executive editor Mary Ellen Schneider and Kathy Skarbeck. MDedge multimedia editor Terry Rudd, and our social media is produced by Kyla Clark. Blood and Cancer is produced by Jennifer Smith. I am your co-host for this show, as well as your producer for MDedge Podcasts, Nick Andrews.